Good afternoon. My name is Joanne Smith. Today I will be presenting a diagnostic summary on antisocial personality disorder. Personality disorder is a persistent pattern of emotions, cognitions, and behavior that results in enduring or lasting emotional distress for the person affected and/or for others, and may cause difficulties with work and relationships. That's according to the American Psychiatric Association. A personality disorder affects the ways in which a person thinks, perceives, feels, behaves, and relates to others. There is a lasting pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture. It's pervasive and inflexible and has an onset in adolescence or early adulthood. It is stable over time and leads to distress or impairment. That is according to the DSM. There are 10 total personality disorders. The DSM breaks up these personality disorders into three major groups. Cluster A is odd and eccentric. Cluster B is dramatic, emotional, erratic. And cluster C is anxious, fearful, and avoidant. Specifically, antisocial personality disorder is part of cluster B, described as dramatic, emotional, or erratic. A person who suffers from antisocial personality disorder consistently demonstrates a pervasive pattern of disregard for and violation of the rights of others. Antisocial personality disorder is the disorder that makes people uncaring. Otherwise known as sociopathy, dissocial personality disorder, psychopathy. Antisocial personality disorder is on a spectrum and can range in severity. Psychopaths are considered to have a severe form of antisocial personality disorder. Again, the persistent pattern of antisocial personality disorder sufferers is disregard for and violation of the rights and needs of others. Clients with antisocial personality disorder have a history of failing to comply with social norms, and they perform actions that most of us would find unacceptable. Some of the symptoms and cardinal features of this disorder: manipulation and deceit are key features. Also, self-centeredness, impulsive behavior, irresponsible behavior, and even criminal behavior. A person with antisocial personality disorder usually does not show any remorse. They may act indifferent to the outcomes of hurtful actions or rationalize the reasons for harming or deceiving others. They simply won't care for other people's feelings. To be diagnosed with antisocial personality disorder, you must be at least 18 years old, have evidence of conduct disorder with onset before age 15 years old. The antisocial behavior does not only occur during the antisocial behavior doesn't only occur during schizophrenia or bipolar disorder. To be diagnosed, you also must demonstrate a pervasive pattern of disregard for and violation of the rights of others, again, occurring since age 15, as indicated by 3 or more of the following: failure to conform to social norms with respect to lawful behaviors, as indicated by repeatedly performing antisocial actions that are grounds for arrest. For example, harassment, or theft, like stealing from friends or family, deceitfulness, as indicated by repeated lying, use of aliases, assuming false identities, or conning others for personal profit or pleasure. Impulsivity or failure to plan ahead, frequent relationship changes, repeatedly changing employment or residence or sexual partners are all examples of this. Irritability and aggressiveness. For example, repeated physical fights or assaults. Reckless disregard for the safety of self or others. Examples of this are speeding, driving while intoxicated, or neglecting a child. Consistent irresponsibility as indicated by repeated failure to sustain consistent work behavior or honor financial obligations. Lack of remorse as indicated by being indifferent to or rationalizing having hurt, mistreated, or stolen from another. Etiological issues. Etiology, or the study of origins, has to do with why a disorder begins and what causes it, and it includes biological, psychological, and social dimensions. It's not known why some people develop antisocial personality disorder, but both genetics and traumatic childhood experiences, such as childhood abuse or neglect, are thought to play a role. A person with antisocial personality disorder will have often grown up in difficult family circumstances. One or both parents may misuse alcohol, and parental conflict is very common. Unstable or erratic parenting, harsh parenting, inconsistent parental discipline may increase the likelihood that conduct disorder will evolve into antisocial personality disorder. A person with a cluster B disorder typically has difficulties regulating their emotions and behavior and maintaining relationships, which would support the theory of a tumultuous upbringing. The likelihood of developing antisocial personality disorder in adult life is increased if the individual experienced childhood onset of conduct disorder before the age of 10 and accompanying attention deficit hyperactivity disorder. So if a child has had conduct disorder before 10 and ADHD, the likelihood of developing antisocial personality disorder in their adult life is increased. So there are some differential diagnoses attached to this disorder. There are other conditions which share similar signs and symptoms with antisocial personality disorder, and care must be taken to correctly analyze individuals who present with signs of antisocial personality disorder to distinguish their symptoms from other disorders. Considering the history, age, criminal activity, substance use, etc., of the person are just some of the things to take into consideration when attempting to arrive at a diagnosis of antisocial personality disorder. Other disorders can coexist in the same individual at the same time with antisocial personality disorder, and that's usually called comorbidity. Some of them are a better fit than antisocial personality disorder, so you have to be really careful. They include conduct disorder, substance use disorder, schizophrenia, bipolar disorder, narcissistic personality disorder, histrionic personality disorder, borderline personality disorder, paranoid personality disorder, and just your plain old criminal activity. So we would diagnose with conduct disorder and not antisocial personality disorder if the individual meets the criteria for antisocial personality disorder, but is younger than 18. We can also diagnose with conduct disorder and not antisocial personality disorder if the criteria for antisocial personality disorder is not quite met and the individual is over 18. So they have some of the features, but not all of them, and they're over 18. So you can diagnose someone over 18 with conduct disorder and not antisocial personality disorder. Another disorder that would be part of the differential diagnosis is substance use disorder. When antisocial behavior in an adult is associated with the substance use disorder, the diagnosis of antisocial personality disorder is not made. Unless the signs of antisocial personality disorder were present in childhood and have continued into adulthood, then you can diagnose this. When substance use and antisocial behavior both began in childhood and continued into adulthood, then you can diagnose for both a substance use disorder and antisocial personality disorder if both of the criteria are met. A person exhibiting antisocial behavior exclusively during the course of schizophrenia or bipolar disorder should not be diagnosed with antisocial personality disorder. So you might find someone who's having a schizophrenic episode or a manic episode associated with bipolar disease, and they might have symptoms that look like antisocial personality disorder. However, you cannot diagnose them with antisocial personality disorder if they're only having those symptoms while they're having a schizophrenic episode or a bipolar manic episode. So the following personality disorders may also be confused with antisocial personality disorder because they all have certain features in common. It is important to note that if an individual has personality features that meet criteria for more than one personality disorder, they all can be diagnosed. So someone can have 2 or 3 personality disorders. So narcissistic personality disorder and antisocial personality disorder, they share a tendency, people with these disorders share a tendency to be tough-minded, glib, superficial, exploitative, and they lack empathy. However, a narcissistic personality disorder does not include characteristics of impulsivity, aggression, or deceit. Also, an antisocial personality does. Absolutely. Impulsivity, aggression, and deceit are very much a part of the antisocial personality features. Also, antisocial personality disorder individuals or people with this disorder may not be as needy of the admiration and envy of others. A diagnosis of narcissistic personality disorder should be considered over antisocial personality disorder if the person lacks a history of conduct disorder in childhood and criminal activity in adulthood. So these 2 disorders, you have to differentiate between these 2 and make sure you don't find like criminal activity and you're trying to diagnose narcissistic personality disorder, or if there's a lack of conduct disorder, then you probably wouldn't diagnose antisocial personality disorder, although it can happen, but these are just these little things that you have to differentiate. So histrionic personality disorder and antisocial personality disorder, excuse me while I just turn this around a little bit. There we go. Perfect. Well, it was better the other way. There we go. Okay, I'll leave it that way. Antisocial personality disorder and histrionic personality disorder share a tendency to be impulsive, superficial, excitement-seeking, reckless, seductive, and manipulative. Individuals should be diagnosed with histrionic personality disorder and not antisocial personality disorder if they're more exaggerated in their emotions and do not engage in antisocial behavior. So someone with histrionic personality disorder doesn't engage in antisocial behaviors, and they're very emotional. person with antisocial personality disorder is not so emotional. Borderline personality disorder should be considered over antisocial personality disorder if the individual is emotionally unstable and not aggressive. Because individuals with antisocial personality disorder are very aggressive and exhibit less emotional instability. So borderline personality disorder and histrionic personality disorder should also be considered over antisocial personality disorder if the person engages in manipulative behavior to gain nurturance. Whereas a person with antisocial personality disorder will engage in manipulative behavior to gain profit, power, or some other material gratification. They're not doing it to gain nurturance. They don't really care to be nurtured. They just want power or some kind of material gain. Paranoid personality disorder. If a person exhibits antisocial behavior, it's not automatically antisocial personality disorder. Examining the motives for the behavior is key. If the antisocial behavior is not motivated by a desire for personal gain or to exploit others as an antisocial personality disorder, you can consider diagnosing paranoid personality disorder instead. Because the motive of antisocial personality disorder can be attributed to a desire for revenge. Excuse me, let me correct that. A diagnosis of paranoid personality disorder can be considered if the motive for the antisocial behavior is attributed to a desire for revenge. I hope I didn't confuse you. Although many prisoners are diagnosed with antisocial personality disorder, a person who commits a crime shouldn't automatically receive this diagnosis. A person who commits a crime but doesn't exhibit the inflexible, maladaptive, and persistent antisocial personality traits that cause that significant functional impairment or subjective distress should not receive this diagnosis. So there are a lot of people who engage in criminal activity and they don't have this disorder. But a lot of people who have this disorder will commit a criminal act. So these are just some of those differential diagnoses of this disorder. Oops, went too fast. Go. Antisocial personality disorder affects more men than women. So there is a gender difference. Antisocial personality disorder, again, is much more common in men. There is a difference in prevalence in terms of diagnoses. More men are diagnosed with this disorder. Approximately 75% are male and 25% are female. This could be a reflection of gender bias on the part of the counselor. It may affect the diagnosis of clinicians because they associate certain behavioral characteristics with one sex over the other. Because antisocial personality disorder looks different among the sexes, clinicians may be diagnosing women with histrionic personality disorder over antisocial personality disorder, because the bias is that women are more emotional and men are not. Men may be tending to exhibit the more aggressive traits of antisocial personality disorder, while the women might be exhibiting more just antisocial traits of just like not showing up for work, not, staying committed to their financial obligations, things of that nature. And so that's why maybe men are diagnosed at a much higher rate with this disorder, because this disorder, one of the key features is aggressiveness. So, and that's connected to men in general. Generally speaking, men are considered the more aggressive of the two genders. So antisocial personality disorder looks different, again, among the sexes. Males are more likely to engage in criminal activity and have multiple arrests, traffic offenses, starting fights, history of setting fires, using weapons, being cruel to animals, and showing a reckless disregard for the safety of others as well as themselves. Females are more likely to have impulsivity, multiple sexual partners, lack of remorse, and more likely to have run away from home. While females show more nonviolent antisocial behavior, such as missing work, like I said, or school, the degree of impairment is much more severe for women compared to men and they have lower social support. Again, the assumption is a lot of people who are diagnosed with this disorder will probably commit a criminal act. And there's a lot of research that's done among the prison population with this disorder. And so there'll be a lot more support for those individuals who are incarcerated because they're trying to find ways to do remediation, trying to figure out how to help these people to stop committing crimes and how to treat their disorder, whereas women who are diagnosed with this disorder don't usually, not that they don't commit crimes, but they'll show other symptoms that, like the ones I just shared about, like impulsivity and having multiple sexual partners or just having a lack of remorse. They might not engage in the more aggressive acts of this disorder, like starting fights and starting fires and, torturing animals. They might not do that. And so because of that, they don't have as much support, or they might be misdiagnosed again with histrionic personality disorder. And so they're being treated for something else, that's not helping them. According to Barlow, 3.9% to 5.9% of the clinical population has antisocial personality disorder. So of the people that are diagnosed with a mental health issue, 3.9% of them, almost 6% of them have antisocial personality disorder as their diagnoses. And 1% to 1.8% of the general population has antisocial personality disorder. There are more than 200,000 new cases per year in the United States. A lot of, we already spoke about this, a cultural prevalence. A lot of prisoners have antisocial personality disorder. As many as 47% of the male inmates and 21% of female inmates have this disorder. There is an age prevalence. Antisocial personality disorder has an early onset of symptoms and is diagnosed as conduct disorder in people under 18. Of the children with conduct disorder, 25% are girls and 40% are boys. And they also meet the diagnostic criteria for antisocial personality disorder, but they won't give them that diagnosis because they are under 18. While there is an early onset with sufferers showing signs of this disorder in childhood or early adolescence, symptoms are at their worst in a person's late teenage years and in their early 20s. Well, in their 20s, not early 20s. Usually by the fourth decade of life, there is an improvement in the symptoms, particularly with less participation in criminal activity. That's a good, interesting fact, because it's just interesting why the fourth decade and why not the fifth decade. That might be a good research topic. Yeah, why the fourth decade of life? Midlife crisis? I don't know. Food for thought there. So my theoretical orientation at this moment is probably going to change before I graduate from this program. But at this moment, my theoretical orientation is the Gestalt theoretical orientation in counseling. Many clients with antisocial personality disorder have trouble seeing how they play a role in their own situations. They often have a me against the world mentality or eat or be eaten mindset. They're very combative, defensive, aggressive. It's like, I'm gonna hit them first before they hit me. And so this Gestalt orientation, I feel, would be beneficial to a client with antisocial personality disorder, because this theory doesn't do a lot of deep psychoanalytical digging. to find out, things that happened in your past, in your childhood. They want to deal with the present and what we can do to help your present and future better versus kind of going backwards. With this disorder, I would challenge my clients who are compelled to blame others for how they act or point to an event in their life that they believe made them the way they are. I would challenge that. This theoretical, this gestalt-oriented approach would challenge that type of thinking. I wouldn't spend a lot of time delving into the past to try and discover why they are how they are, but focus them on the present and find ways to cope and manage with their life with antisocial personality disorder, because there is no treatment. We'll get to that in the next slide. I'm going ahead of myself, but this disorder is lifelong and there's not a lot of treatments, but there's a lot of ways to help empower that person to cope with their symptoms and to learn how to socialize, learn how to live in a way that they won't get in trouble, get arrested. And so this orientation and this approach would be a good approach for a counselor to have who is working with clients with antisocial personality disorder, or at least a spouse. Maybe not their whole, clinical, career would be geared in this orientation, but it would help with those clients who do have this disorder. So treatment for antisocial personality disorder can be challenging. There's no conclusive one-size-fits-all therapy for antisocial personality disorder. However, there are treatments available to help clients manage their condition, its associated symptoms, and any comorbidities that exist. If my client, if I were a clinician and I had a client who was a minor, under 18, or even maybe a college student who's still dependent on their parents, I could use the parent management training approach to help treat this individual. This approach would help address socialization and behavior issues, as well as empower the parents with strategies and guiding principles to help deal with their minor child or college-age child. If I was a clinician and I had a client who had a substance use disorder and antisocial personality disorder, I could employ the contingency management approach, along with, of course, required enrollment in a drug treatment program. To encourage my client to stick to their treatment plan, this would be a helpful approach or strategy or treatment, since their abstinence would be rewarded with money, privileges, something good. I could also use this strategy to discourage other negative activity and behavior, such as stealing or lying or assaulting. So this is just basically like, hey, you did good today, you get a star on the star chart. That would be that kind of approach where their good behavior gets awarded and their negative behavior doesn't get awarded. That's just the basics of that one. If I were a clinician and I had a client who was not a minor and was not dealing with substance use disorder, my treatment of choice would be cognitive behavioral therapy or even dialectical behavioral therapy, but I would lean more toward the cognitive behavioral therapy. I would use this therapy to help my client identify and change unhelpful thinking and address distorted thought patterns, such as black and white thinking, overgeneralizing, and catastrophizing, excuse me. Overgeneralizing and catastrophizing. To address this client's strong emotions and tendencies towards self-harm, I could use the dialectical behavioral therapy. I think this therapy was created for borderline personality disorder sufferers, but some of the approaches would be helpful to a person with antisocial personality disorder as well. This approach addresses impulsiveness and poor thinking through mindfulness, emotional regulation, interpersonal relations, and the ability to handle discomfort. Another strategy or another treatment plan I would incorporate if I were a clinician working with someone with antisocial personality disorder is medication. I definitely would include medication as part of the treatment plan for some of my clients who have the co-occurring condition. So I would partner with the client's physician or nurse practitioner to assess compatibility with such medications as Wellbutrin or Strattera for people who have antisocial personality disorder and ADHD. I would offer an antipsychotic. Well, I can't prescribe medicine because I know I'm a mental health professional, but I'd be working with in a perfect world, I'd be on a treatment team and be working with other professionals who are also working with this client in order to address some of their other needs. So one of the other medications we could prescribe is an antipsychotic, antidepressant, or lithium for aggression, and an anticonvulsant to manage impulsivity. These medications do have side effects, but that would be an option as part of the overall treatment plan for this person. Lastly, I would employ, maybe I should say first, because I am a counselor or soon to be counselor, employing talk therapy to address symptoms of anxiety, depression, discuss goals, as well as problems associated with any addictions they might have, relationships, issues, interpersonal skills. I would also encourage self-care strategies like exercise, deep breathing techniques, encourage healthy lifestyle changes, and even participation in a support group. All of these in conjunction, not one over the other, but all of these working together would be beneficial to a person with antisocial personality disorder in helping them cope and deal with their symptoms, since there really isn't a treatment that would eradicate it and and keep them from not having this disorder. Again, this disorder dissipates in a client's 40s. So treatment strategies and approaches would vary if I were a clinician, depending on how close a client was to their 40s or their fourth decade of life. So you have to take age into consideration. This is a disorder that improves with age. The symptoms lessen with age. The symptoms are the most intense in the mid-20s, and they start in adolescence. So this course is chronic, but it does get a little bit better as the person ages. So a counselor who wants to work with people with this disorder, God bless you, would need additional training. They would need additional training to work with sufferers of antisocial personality disorder. To become a certified parent management trainer, you can become certified at parentmanagementtaininginstitute.com/professional-training. Additional training to become proficient in cognitive behavioral therapy is needed in order to treat an individual with antisocial personality disorder. The Beck Institute offers CBT certification online. Additional training in dialectical behavior therapy is needed if you want to work with people with antisocial personality disorder. If you want to apply this treatment, you have to get trained in it. Exit strategies for safety is important for anyone wanting to work with this population. If a client becomes combative, becomes violent, aggressive, you just start to feel, this person might try to hurt me. You might want to have some exit strategies in your office when you have a client like this in your chair. You need lots of supervision because this disorder, one of the key features is manipulation, and you would want to make sure you have a lot of supervision and a lot of people that you can go to as a clinician to just make sure that you're not being taken advantage of, that you're not doing anything to harm the client. Because one of the things I've learned during this research is that people with this disorder, oftentimes the treatment doesn't work because they don't believe they have a problem. They think everyone else has the problem. And if you have a client who is in treatment, it's usually because it's court mandated or because someone significant in their life has basically said, if you don't get help, I'm leaving you. You know, there's something compelling them outside of their own awareness that they have a need or an issue. People with this disorder don't really seek help. So with that said, a lot of supervision is needed, exit strategies. If you are, treating this person in your office and in a closed setting, you want to make sure that you don't have anything in your office that could become a weapon. You need to have very rigid boundaries to avoid being manipulated by a client with antisocial personality disorder. You need to be willing to work on a treatment time. You have to be optimistic that and hope that your client can become a functional member of society if they apply what you are teaching them, and if they really want to change or at least cope with their symptoms better. You got to be optimistic because it could be easy to get jaded. That's probably with every disorder or, mental health issue that a clinician might have to deal with day in and day out. You can get jaded. And so you would want to be careful because the counselor is a key, their disposition and who they are as a person. They bring that into the therapeutic relationship. And oftentimes, individuals with antisocial personality disorder will point to the fact that they didn't feel like their therapist was really cared to help them, Is that a lie? Is that a manipulation? Who knows? Maybe it is. But you as a counselor, you're key. What you're bringing in terms of your energy, your disposition, just be optimistic that if they're there and you're in the room with you, there's hope that they can get better. And you need a lot of patience for this long, arduous road to helping this client find their best baseline. So those are some of the things that you would need as a counselor: patience, optimism, willingness, great boundaries, lots of supervision, exit strategies, and additional training in some of these like CBT, DBT, and parent management training that would help. In conclusion, the common outcome in many psychological disorders can be summed up in this one word: isolation. In Genesis 2:18, God reveals a fact that is relevant to the mental health practitioner today. It is not good for man to be alone. Not good at all. Every disorder that we have reviewed during the semester, they all have this feature in common. They isolate the sufferer from others, whether it's major depressive disorder, schizophrenia, post-traumatic stress disorder, social anxiety, dissociative identity disorder, anorexia nervosa. The most lasting effect of these disorders is their ability to isolate the sufferer from other people, and even sometimes from the individual themselves. An antisocial personality disorder is no different. This disorder is oftentimes seen as this disorder, this person is like a bad person, an evil person, and all they want to do is inflict pain on others. And that's a little bit true. There's some truth into that. But this disorder also affects the sufferer, even if they're not aware of it, because it isolates them. It isolates them. They're not able to have the relationships that they could have if they didn't have this disorder, and it's isolating. And so as mental health clinicians to be, if we ever come across, and I'm sure we will, individuals with antisocial personality disorder, hopefully we'll have this in mind to remember that even if they're not seemingly responsive to the treatments, even if they seem resistant to even being in your office, that deep down they're hurting, they're suffering, and just your interaction with them could help them not to allow this disorder isolate them. And that concludes my presentation on antisocial personality disorder. I enjoyed class and I learned so much, and I hope to be working with you again, Dr. Christian.